crash course of peripheral blood morphology. Today we are delighted to have Dr. Nahla Al-Ghasham, who is a hematopathology consultant at King Abdulaziz Medical City in Riyadh. Also, she was a former assistant professor in Al-Qasim University. Dr. Nahla will be addressing leukemia and lymphoma morphology. Please type your questions in the Q&A or comments. Dr. Nahla, the floor is yours.
Thank you very much, Dr. Firas. I hope my voice is clear for everyone. I would like to start thanking the Saudi Society for Blood Disorder for this opportunity. And also I would like to thank my colleagues, Dr. Mohammed Al-Mohammadi and Dr. Haytham Khoghir for their excellent presentation the last 2 days. It was very nice introduction for my talk today. They made it easy for me to prepare and to present it today. Today I'll talk about the leukemia and lymphoma morphology, the peripheral blood morphology in the blood smear. And as you know that this is a very big topic. Leukemia and lymphoma is a heterogeneous group of diseases. We have a dedicated book, the WHO classification for hematopoietic disorders. So it wouldn't be logic if we will present all the cases of all the morphology. But at least I choose a number of cases, 17 cases that we will go through. They will cover some leukemia and some lymphoma diseases that may have a peripheral blood morphology finding that pathologists, technologists, and fellows, interested clinical fellows that if they would like to share in the diagnosis of the peripheral blood, it may help them. My cases arranged randomly so that you can, you wouldn't predict what's the next case or what's the presentation. We will discuss the patient's clinical presentation, CBC findings, and then the morphology, and we'll try to go through the diagnosis. I'll try to make it interactive if that time will help me. I'll try my best. So to start with, I would like to explain the role of peripheral blood smear in the diagnosis of lymphoma and leukemia. First of all, if you receive the call about an abnormal circulating blood cells, then you need your peripheral blood smear to confirm this abnormal count, circulating abnormal cells. So it's number one to confirm the abnormality in the CBC and diff. And two, it's the first step toward a final diagnosis. Sometimes you can make the way shorter if you detect an abnormality and then target the flow panel that you want to do it, or the cytogenetic fish probe that you choose to do it, which will gonna be diagnostic, and then the story is end there. So sometimes the peripheral blood smear is diagnostic enough for the cases of leukemia and lymphoma, especially for those patients whom choose not to go with the bone marrow examination. So what can we spot in the peripheral blood smear? We can find the immature cells, the blast and the blast equivalent cells, and we will gonna talk about the blast equivalent cells. And you can enumerate and count the blast, circulating blasts, to get the threshold of acute leukemia, or to ask for further bone marrow examination to examine and enumerate the blast there. Also, in the peripheral blood smear, you can also confirm the overproduction of mature cells like red blood cells, platelet, and white blood cells in a case of myeloproliferative neoplasms, in a case of polycythemia vera, essential thrombocythemia, or CML cases. And also you can detect an abnormal cell morphology dysplasia, as Dr. Haytham also explained yesterday. When the patient have a cytopenia, usually clinician will request a peripheral blood smear examination to visualize the abnormal cell morphology and for the diagnosis of myelodysplastic syndrome. In case that you have an overproduction, or what we call effective production or effective hematopoiesis, but Also, you have an ineffective erythropoiesis and dysplastic cells together could be in a different cell lines. Then the patient may have a myeloid dysplastic syndrome or slash MPN, like the cases of CMML, GMML, cases of atypical CML, or MDS, MPN, unclassifiable. You may have overreduction of lymphocytes with or without abnormal looking lymphocytes, and this could be diagnostic for leukemia lymphoma, like the CLL diseases or Mantle or other lymphoma cases that they may have a spill in the peripheral circulation. So you will get abnormal CBC result, and when you put your eyes in the microscope, you will detect sometimes and get a clue of the abnormal cells. طيب. Always connect your dots. Always connect your finding with the patient's age, the clinical representation, and the history. If the patient have, for example, hepatosplenomegaly lymphadenopathy, history of drug before, history of previous chemotherapies, history of infection or medication like GCSF, try to avoid mislabeling the patient with something else. Always, and I always ask my resident to go to the previous CBC and DIF and get the trend of the finding. Is the patient is progressing or regressing? Is his, for example, is he building up blasts through a time, or if there is a thrombocytosis or thrombocytopenia, which is abrupt, acute, or chronic for a long time? And also go for your previous peripheral blood smear. Sometimes we do a peripheral smear and description as a baseline, and then with the time, you may go back to it and read it, because we don't save the peripheral blood smear slide for a long time. So write your report in details so that it will help you later on. And also look for other laboratory results or radiological results that may help, because you know that the progress note sometimes for the clinical people, our clinical colleagues, it's busy. So getting an information sometimes it's not easy. Patient radiology result for lytic lesion, for example, or hepatosplenomegaly or lymphadenopathy can help. And also other laboratory results, like if the patient did a tissue biopsy before, or if the patient, for example, have biomarkers for something. Always connect the dot to get the final result, and be safe then, Saro. Don't try to report a peripheral blood smear without correlating the patient CBC and the other presentation, so that you will not gonna mislabel your patient. طيب, I'll start with my cases. Through the cases, we'll go through the findings in the leukemia and lymphoma. The most common, maybe not an everyday cases, like at least you can see it. First case is a 34 years old female presented with a dizziness, palpitation, and shortness of breath for 3 days, found to have splenomegaly. And in the CBC, you have a marked leukocytosis, hyperleukocytosis with marked anemia and thrombocytopenia. And you will notice that in the peripheral count, you have diff count, you have a predominance of lymphocytosis with dominating the diff picture. So presence of adult female with a splenomegaly and lymphocytosis is alerting, especially with this hyperleukocytosis. And definitely you will go to your peripheral blood smear. And this is the peripheral blood smear, confirming the hyperleukocytosis. So you have like a monotonous presentation of the cells. They are almost similar to each other, all the white blood cells. And also we have basket cells or smudge cells, as Dr. Haytham explained yesterday, many fragmented cells in between. And we have all these monotonous cells. A higher power magnification, you can see that these cells are small, mature, scant cytoplasm, clumped chromatin, of course, a granular cytoplasm. Some atypical larger forms of cells are present. We have these rare neutrophils here in the corner, and we have also other monocytes here. So more magnification for the pictures. Do you have any clue for the for these patients? What's your provisional diagnosis? Please type your answer in the Q&A. Exactly. Bushra is right. This is a case of chronic lymphocytic leukemia. The very nice monotonous morphology of the small mature lymphocytes is characteristic. Of course, you can't confirm this by morphology alone, but you would say that this is lymphoproliferative disease, mostly B cells and could be a CLL. And you will gonna go and request the flow cytometry to confirm the clonality and the immunophenotyping, and you can go further from there. Okay, so the flow cytometry detects a 65% event in the lymphocyte gate, and they are positive for a clonal for Kappa with 5 co-expression, DIM, CD20, 19 is positive, 23 is positive, and 200, which is very characteristic for the CLL diagnosis. Also, it's positive for 79A, and as I told you, it's a Kappa light chain restriction. So the phenotype, the morphology is going with the diagnosis of CLL. The FISH is negative and the karyotype is failed, and the final diagnosis is a chronic lymphocytic leukemia. Just to be to take care of a few points about the CLL. In a CLL, you need to make sure that you don't have much of the pro-lymphocytes. In case that you have many of these cells, which is larger than the mature small lymphocytes, it's larger, more abundant cytoplasm, irregular nuclear, and prominent single nucleoli. This is a very characteristic finding for a pro-lymphocytes. And if you have much of these, for example, of more than 55, then this is diagnostic for pro-lymphocytic pro-lymphocytic leukemia. However, in the case of a classical CLL, you should have less than 15% of the pro-lymphocytes. And in case that you have, for example, from 15 to 55 of these pro-lymphocytes, then we call it atypical CLL as per 2017 WHO. So count your pro-lymphocyte in the case of the CLL, and also make sure that the patient wouldn't have an autohemolytic anemia. Look for the red blood cells for the presence of spherocytes, because it's well known that the patient of CLL may have an autohemolytic anemia. Okay, case 2. This is a 46 years old male patient presented with a 3-week history of generalized body weakness, loss of appetite, and high fever and shortness of breath. The patient have a leukocytosis, marked anemia, and thrombocytopenia. And the technologists will call you about 93% circulating blast. So you will need your peripheral blood smear for the at least provisional diagnosis. So this is the type of blast that you have in the blood smear. Small to medium in size, very high INSI ratio, scant cytoplasm, and we have a very large nucleoli, or what we called thumbprint or cupping. I prefer to call it a drop of water over the nucleus. So other type of the cells sharing the same morphology, it's if you can go higher, you may appreciate the fine granulation here in this blast. This could be a monoblast, for example, with vacuolation, but definitely it's have a fine granulation. Okay, the rest are showing the same morphology: high INSI ratio, open chromatin, prominent large single nucleoli with cupping morphology. This is also another 2 blasts, one of them showing the fine granulation in the cytoplasm. It shows more abundant cytoplasm here. And this one, if you would imagine and believe me that there is a fine small our rods here. And as we know that the our roads, it's diagnostic for myeloblasts. So would you agree with me that this case could be, of course, it's acute leukemia. We have a 90% and more circulating blast. So this is an acute leukemia. But can we define the type of blast by morphology? Is it a lymphoblast or myeloblast in this case? Yes, so it looks like a myeloblast, although it's not showing the usual morphology of the myeloblast with larger size, abundant cytoplasms, some irregular nucleus, but presence of these fine granulation and rare our roads, it's giving us the clue. And this cupping is very characteristic for a cytogenetic finding. Molecular finding. This is the flow cytometry of this patient leukemia. So you can get that we have a 40% total event in the blast gate. They are positive for MPO 11733, 15 partial, 64 11B, 38 71, and 123, and negative for 34 and DR, and all other myeloid and lymphoid markers. So the morphology, the rare our roads, the fine granulation, this phenotype is characteristic and diagnostic for acute myeloid leukemia. And the presence of cupping on the nucleus and the negativity of CD34 and HLA-DR is highly suggestive for presence of NPM1 mutation or FLT3 mutation. So of course we go through, the patient went through the bone marrow examination and cytogenetic and molecular study. And the FISH was negative, the karyotype was within normal, male karyotype, and the molecular study detected the positivity for NPM1 ITD mutation for FLT3 and IDH2. So the patient diagnosed as a case of acute myeloid leukemia with mutated NPM1. And I think couple of you I saw in the Q&A get the finding of expected NPM1 mutation from the morphology and the flow cytometry. Okay, case 3. It's a 70 years old male presented with epigastric pain and hemoptysis with a history of disorientation, confusion, and the brain CT reveals an acute subacute infarction and hemorrhage. This is his count. So we have also marked leukocytosis, anemia, and thrombocytopenia. And we called about a circulating blast of 92%, but also the patient have abnormal coagulation profile with prolonged PT and low fibrinogen. So from the history and from the CBC finding, death and abnormal coagulation profile, and the patient is disoriented with acute subacute infarction and hemorrhage in the CT. What is the most urgent? Exactly. M3. We need to rule out APL M3 acute promyelocytic leukemia. So you will go with your peripheral blood morphology, and you will find that the patient in the peripheral blood have those very nice circulating abnormal promyelocytes. However, they look microgranular or hypogranular. And I think Dr. Haytham yesterday explained this very nicely. So we have a uniform bi-looped butterfly abnormal morphology, and we have these fine granulations in the cytoplasms in the cytoplasm, which is going with the hypo or microgranular variant of M3. And also, you can notice that we have also a cupping here, or thumbprint, or drop of water over the nucleus. So with the very high leukocytosis, this is going also with the micro variant of M3. It's known that the microvariant will have increased or leukocytosis to hyperleukocytosis, together with the similar abnormal coagulation profiles and fibrinogen and others. So from morphology, if you go carefully through the blood smear, even if it's micro, granular and variant, hypogranular variant, you will gonna find these phagoid cells with multiple hour rods in the cytoplasm. And we are lucky enough to find in the same field another hypogranular abnormal promyelocytes with hour rods, and also this one have a multiple small hour rods. So this is a very nice case of microgranular M3 variant. However, it's very challenging sometimes. It wouldn't be easy like this one, and these cases could be or confused with the cases of acute myelomonocytic and acute monocytic leukemia because of the similar morphology of the cells. And this is the famous picture from the WHO showing us the monoblasts, promonocytes, which is blast equivalent, and abnormal monocytes. And I put here our patient microgranular or hypogranular abnormal promyelocytes. And I would understand if any junior resident or fellows or whoever would miss or confuse between the two. You need to train your eyes to see different shapes, but the most things that it may help that the abnormal monocytes, the nucleus is more condensed and the cell's convolution is very coarse, that you wouldn't see the overlapping of the two, the lining these between the two, for example, loops of the nucleus. Also, the cytoplasm may contain the vacuolation and very fine granulations. And if you look carefully in your blood smear, you will gonna find the phagoid cells. You will gonna find the hour rods or multiple hour rods in the same cells, and this may help you a lot. For example, a cells like this, very nice, yes, it may resemble a promonocyte or something, but go through your slide, examine as much as you can of the cells. And if you are wondering, get a second opinion and get your urgent FISH request for BMR RARA. Be safe than sorry. Do it. If it's negative, then continue with your examination as this is an acute myeloid leukemia, definitely. But what subtype, this is, you will gonna work on it. But don't miss a hypogranular M3 because that you thought that this is, for example, myelomonocytic leukemia or something. So this patient have rearrangement by FISH and also confirmed by the karyotype, and that also the molecular came positive for FLT3. I showed you the cupping before. So the patient is diagnosed as a case of acute promyelocytic leukemia with BMR RARA, and also the FLT3 is positive in this case. In the same week of this case, we get another case of young patient. That patient, I think, was a 70 or 80. This patient is a 14 years old, presented to ER, complaining of fever, night sweat, hemoptysis, rectal bleeding, and hematuria. He was alert, no CNS symptoms, and no organomegaly. And his count shows a mild leukocytosis, anemia, and marked thrombocytopenia. His coagulation profile wasn't bad, but we've been called about a promyelocyte of 61. And this time, the promyelocyte was clear enough for even the technologists to call it abnormal promyelocyte circulating in the peripheral blood. And there was like a 7% blast. So yes, this is a very nice hypergranular M3, the classic with coarse granulations, the abnormal morphology of the nucleus. It was a very clear. FISH was requested, being positive, karyotype is confirmed, and the patient diagnosed as acute promyelocytic leukemia with BMR RARA. Okay, case number 4 is a 58 years old female presented to local hospital with fever, for 4 days, epistaxis and bilateral painless cervical lymphadenopathy. CT reveals lymphadenopathy above and below diaphragm, but no hepatosplenomegaly. Hyperleukocytosis, anemia, and marked thrombocytopenia. And also you have a circulating blast by CBC. So lymphadenopathy, blast, anemia, thrombocytopenia, and hyperleukocytosis. Very nice picture of blasts. Definitely an acute leukemia. Blasts are variable in size, small to large, high NC ratio, prominent multiple nucleoli, slightly open chromatin, agranular cytoplasm, some of them showing irregular nuclear contour, hand mirror, if you are a fan of these changes. So no granulations, no our roads. What would you think? Is this a myeloblast or a lymphoblast? This is a lymphoblast, yes. This is a lymphoblast, and this is an acute leukemia. Mostly a lymphoblast, you need your phenotyping to confirm this, and you need the immunophenotyping even to confirm that is this a T-lymphoblast or is it a B-lymphoblast? But to start with, definitely, this is an acute leukemia. So the flow cytometry, 90% event in the blast gate. They are 34 partial positive with TDT, and 10 positive, 19, 22, 24, 38, 66, 123, 81, and 58, negative 4, 20, 21, 13, 33, and all other examined marker. So this is a B-lymphoblastic leukemia. Patient have translocation 610 and deletion of B53. Next case. A 54 years old female with abdominal pain and palpable spleen of 20 centimeter below costal margin. So the patient have splenomegaly. The CBC, we have a leukocytosis, we have anemia, thrombocytopenia, mainly neutrophil, the diff, with some circulating blast, 4%. You have also left shift. You have nucleated RBCs. So this is what we called a leukoerythroblastic blood picture. And the leukoerythroblastic blood picture, by definition, is having a left-shifted granulocytes together, up to the stage of circulating blast. And also you have a nucleated RBCs in the peripheral blood. So these patients have leukocytosis with the leukoerythroblastic blood pictures. And also from the laboratory, you would notice that the patient have a very high LDH. So splenomegaly, LDH, leukocytosis, leukoerythroblastic blood pictures, adult patient. Let's see the peripheral. Okay. So we have, yes, a leukocytosis, mainly of neutrophils, some band. We have a left-shifted granulocytes, metamyelocytes. And you can notice also we have a very large platelet, or what we called megakaryocyte cytoplasmic fragment. This is not even a giant platelet. And this is maybe the cause that the patient is called having thrombocytopenia. This is a very huge size platelet. And you can notice this from the patient CBC. The MPV, the main platelet volume, is 12.5, which is high. Also from the low power, you can see that we have some eosinophils, monocytes, we have nucleated RBCs. So yeah, this is a leukoerythroblastic blood pictures. a high power magnification, very nice morphology of the neutrophils, band, metamyelocytes, myelocytes, very nice morphology. They are not reactive, no toxic granulation or vacuolation, not dysplastic. They looks okay morphologically. We have here a lymphocytes, and you can see here we have a good number of platelets with large giant, or we call it anisocytosis in the platelet with variability in granulation. We have a hyper segmented neutrophils, and we have basophil, but we don't have basophilia. Okay, we don't have basophilia, we don't have monocytosis. Mainly granulocytic leukoerythroblastic blood picture. So what do you think? What we are dealing with in this lady? Myeloid leukemoid reaction. Leukemoid reaction, you would have a reactive change in the, and it's usually only CML could be a good guess. You need to confirm it by your fish for BCR-ABL. MDS, no, they looks very nicely morphologically. MF, thank you. Yes, most likely this is an MF, and you need to go. So most likely this is an MPN case, okay, myeloproliferative neoplasm, and you need to do a bone marrow to confirm this. This is a case of primary myelofibrosis. So this is a case of primary myelofibrosis. The bone marrow shows increased fibrosis in the bone marrow with grade 3 out 3 by reticular and trichromatic staining. The patient molecular have a JAK2 positivity and negative for BCR-ABL, and the karyotype came normal. So the patient diagnosed as MPN, primary myelofibrosis over fibrotic stage. So she's almost have all the minor criteria, and we confirmed the major criteria. Patient have the fibrosis, patient not a BCR-ABL or don't have other neoplasm, hematological neoplasm, not an MDS, not BCR-ABL positive CML. Patient is positive for JAK, also with a minor criteria of splenomegaly, leukocytosis, leukoerythroblastic blood picture, the high LDH. This is a case of MPN, primary myelofibrosis over fibrotic stage. Okay, next case, case 6, a 16 years old male presented with cough and shortness of breath for 5 days. He was admitted with COVID-19 pneumonia. He was found to have a hepatosplenomegaly. So per count, the patient have a leukocytosis, mild anemia, and moderate thrombocytopenia. We have eosinophilia in this patient, and we have a circulating blast. Hepatosplenomegaly, young patient, 16 years old, with eosinophilia and circulating blasts. Okay. Definitely we have eosinophilia, and definitely we have the circulating blasts. And these eosinophils looks abnormal. They are dysplastic. They have uneven distribution of the granules, hypogranular mostly. And the blasts, medium in size, high in C ratio, agranular cytoplasms. We have here a mature lymphocytes with another lymphoblast and eosinophils, abnormal eosinophils. Another picture with abnormal eosinophil. This is reactive neutrophil and band. We have here a 2 blasts with basophilic cytoplasm, scant agranular. We have here a lymphocytes and a blast. So what do you think? Eosinophilia, AML could be with eosinophilia, you would like to, for example, put in your differential the AML with inversion 16 and translocation 16-16. Yes, since that there is an eosinophilia, but we don't have the monocytosis. So you need your immunophenotyping, definitely. Definitely you need your immunophenotyping. Like this is a case of acute leukemia. We have a more than 20% circulating blast in the peripheral blood. So you would recommend a bone marrow examination, immunophenotyping, and full cytogenetic molecular study for this patient. Morphology is not enough, as you know, these days. So the immunophenotyping, 50% by flow in the blast gate. They are 34 positive and CD19 positive. They are TDT positive. They are CD20 positive, CD10, 22, 24, 21, 38, 13, and 33, 66, 58, 81, 1, 2, 3, 9, 71, and HLA-DR. So this is a B-lymphoblast. So a B-lymphoblast with abnormal eosinophils. You would expect a specific translocation, which is 514. So we called our scientist and we asked for a karyotype, and yes, she detected an abnormal chromosomal analysis. The patient found to have a translocation 514 plus also translocation 710, deletion 9, and these diagnostic for a B-lymphoblastic leukemia with translocation 514. Yes, there is another cytogenetic abnormality. So the patient diagnosed as B-lymphoblastic leukemia. But of course, you would put in your differential at the beginning from the morphology, since that there is an eosinophilia that may be inversion 16 and translocation 16-16, myeloid, but the morphology was very lymphoid for the blast. Is eosinophilia usually associated with lymphoblastic leukemia? No, no, of course not. طيب. Case 7, a 4-year-old boy with history of fatigability, decreased appetite for 3 months. Examination, he looks well. There is a bruise over the right leg and no organomegaly. So he have mainly anemia. He's not in leukocytosis. Platelets is okay, but we have a circulating blast. You can tell that the patient is not a leukocytosis by a low power magnification. But we have a few blasts, small to medium, neutrophils, and basket cells or fragmented cells. The blast looks what? And this is a nucleated RBCs. What do you think about the blast morphology? Yes, a lymphoblast. Looks like a lymphoblast. High NC ratio, basophilic cytoplasm, agranular, slightly clumped chromatin, inconspicuous nucleoli. Some of them shows more prominent nucleoli. So yes, this is a lymphoblast. And the flow cytometry shows a 53% total event in the blast gate. They are with a T cell phenotype with cytoplasmic CD3, service CD3, 1A, 24, 578, 9, 10, 38, 99, 81, and TDT. 34 is negative in this case. The fish detected the B16 deletion, chromosome 9, and also it was, I think, confirmed by karyotype also, and the patient diagnosed as T-lymphoblastic leukemia. If you remember that in that case of the B lymphocytes, B-lymphoblastic leukemia, we saw the hand mirror, we saw the very aggressive morphology of the cells. it was, you may assume that that case may be a T cells. This one, you would think that, okay, this case could be a B cells, very fine blast, a small, you wouldn't expect that this is a T, but nowadays patients are, they are not a textbooks anymore. So whatever you are used to describe your blast, there is always exception. Case 8, a 5-day-old boy. 5-day-old boy referred to our hospital as life-threatening pericardial and pleural effusion. He is a preterm, 32 weeks with Down syndrome features. Examination, not distressed, with a murmur, soft abdomen, no organomegaly, and not edematous. His count shows a leukocytosis, anemia, platelet was okay, and circulating blast of 64. So Down syndrome, 4 days old, leukocytosis, and blast. This is the morphology. Of course, there is a blast, but there is also a mature cells, neutrophils, band. We have a number of nucleated RBCs, this one, and this one also nucleated RBCs. There is some change in the erythrocyte, and also we have a variability in the size, anisocytosis in the platelet clumps, giant platelet, large platelet. This is the high power for the blast, variable in size, small to large, high INSI ratio, variable amount of cytoplasm, most of them are of scant cytoplasm, fine granulation in some blast, prominent nucleoli. This blast shows more granulation. Reactive neutrophils with vacuolation, toxic granulation, and we have also 3 small blasts here, high INSI ratio, convoluted nucleus, prominent small nucleoli, 1 to 2, scant cytoplasm, agranular. If you can notice here in this blast, there is like a small blips and from the cytoplasm. Okay, more blast, larger in size, basophilic cytoplasm, agranular. This one have a vacuolation. Also, this small blast have also the cytoplasmic blips that we saw before. We have here a nucleated RBCs. So what do you think? Down syndrome, 4 days, circulating blast, 60% leukocytosis. So somebody here saying that this is AML M7. Okay, what do you think? TAM, thank you. Could be a TAM or could be so the flow cytometry detects a 58% in the blast gate. They are positive for 34, 117, 33, 36, 38, 56, 7, 9, 123, 42A, 42B. You can see here it's a partial, the 42 and 61, it's partial, and also for the 42B, it's partial. But both of them are, all the cell population in the blast gate are 34 and 7. So co-expressing CD7. MPO is negative and HLA-D are also negative. FISH is positive only for the trisomy 21 and also the karyotype. So the diagnosis for this patient, looking to his age, a newborn with Down syndrome, you would think that this could be an abnormal, transit abnormal myelofibrosis. Of course, you could call it a myeloid leukemia associated with Down syndrome, and you would not be able to differentiate between the two conditions. the presentation, the clinical, the morphology, even the immunophenotyping, both of them usually shows a megakaryocytic differentiation. The thing is that in the TAM, it is usually will go spontaneously within the first 3 months of life. However, these patients have a higher chance to get the myeloid leukemia later on in their life. GATA1 mutation is the pathognomonic for the TAM, but also it may happen with the myeloid leukemia of Down syndrome. So this patient was diagnosed as TAM. Unfortunately, he passed away after a few days. But the presentations is going with a TAM for Down syndrome. Case 9. A 65 years old female known to have persistent anemia and thrombocytopenia. So no leukocytosis in this case. We have anemia of 86, normocytic normochromic anemia. We have a platelet with normal thrombocytopenia with almost low MBV. And this is the peripheral blood morphology. What do we have here? What do you think? What is the catchy finding in this blood smear? Rollo, yes. We have a very nice Rollo formation. And we have, yes, circulating plasma cells. Thank you. So the circulating plasma cell in this case was approximately a 24% and you can see here plasma cells is easy sometimes and very difficult other times. You have the blue cytoplasm, the Goldjuhoff, the eccentric nucleus. This is a PET in this case. This is a PET immature plasma cells because of the nucleus and because of the prominent nucleoli. Usually as the plasma cells goes mature, it will acquire more abundant cytoplasm. It will become larger in size and the chromatin will be more condensed. So this could be, it's not a plasmablast, those cells, but they are not the very nice mature plasma cells. In this case, you need to confirm the clonality of the plasma cells. You will do your enumeration on the slides, morphology, and then you will gonna go and run your flow cytometry for clonality. This patient, we did it on bone marrow. It was better sample and more cellular, and we detect a 40% clonal plasma cells with lambda light chain restriction. Peripherally, there was like a 24% circulating plasma cells, which is going with the diagnosis of a plasma cell leukemia. The patient found to have a complex karyotype. And finally, plasma cell leukemia was called out. So in case of a plasma cell leukemia, you need to be more careful. There is a wide range of presentation for plasma cells, either in the bone marrow or peripheral blood. Sometimes you will have a very nice plasma cells with eccentric nucleus. Sometimes you will have more blastoid morphology. And the other, you will find that plasma cell is very fragile and you will gonna get these like a hairy projection in the peripheral blood and bone marrow. So be careful. And the tricky things that sometimes if you will flow it, you will not gonna get the enough number for analysis because the plasma cells is prone and easily lost before analysis. So we prefer always the bone marrow because it will be more cellular and sometimes will be more representative. And if you have the trypan biopsy, this is well and good. You will gonna go and do your immunostaining on the trypan biopsy for clonality. So be careful, because if you saw some cells like this, you don't want to go and call it a hairy cell leukemia. Just go with full pictures of all the cells and try to do, of course, flow cytometry. Case 10. This is a 28 years old male presented with headache and abdominal pain, found to have marked leukocytosis of 400, more than 400, anemia, normocytic normochromic anemia, and normal platelet. So what is this? We have also nucleated RBCs. What do you think? Do you have any guess? Very hyper leukocytosis. Very hyperleukocytosis, heterogeneous cells. We have from low power, many neutrophils, left shift, nucleated RBCs, some apoptotic cells. Yes, yes, I agree with you. So predominance of neutrophils and band, segmented neutrophils and band, myelocytes, some promyelocytes, metamyelocytes, occasional eosinophils. I'm sorry about the pictures, but believe me, this is a very nice granulation. So I blame the camera. We have here a blast. So blasts, maybe this is another blast or mono, could be. Band, myelocytes, and some metamyelocytes. So we have this is a basophils in between. So we have a hyperleukocytosis, we have predominance of neutrophils, myelocytes, some metamyelocytes, very rare blasts in between of could be around 2 to 3% maximum. So if you think that this is a chronic disease, a case of MPN, myeloproliferative neoplasm, yes, I agree with you. Most of you mentioned that this could be a CML. What test that will gonna confirm your finding? For chronic myelogenic leukemia, Fatma said CML chronic phase. I agree with you. The picture is going with CML chronic phase. So what tests will gonna confirm this assumption? Yes, PCR-ABL by FISH is the gold standard for the confirmation of the diagnosis. And this patient came to be positive for rearrangement ABL, CML-ABL, APL1 PCR, and the karyotype is positive for translocation 922, and the molecular also for B210, BCR-ABL mutation. So this patient diagnosed as chronic myeloid leukemia, BCR-ABL1 positive in chronic phase. Case 11. Case 11, this is an 88 years old male admitted with pneumonia and sepsis, found to have a leukocytosis, so white blood cells of 71.6, hemoglobin 78, platelet 130. And you can see here we have mainly neutrophils with left shift, rare blast, 1%, and nucleated RBCs. This is the peripheral blood. So leukocytosis, those are neutrophils, but they looks abnormal, definitely. Not all of them, but at least this one, this one, this one, and this one. Hypolubated, bilobed, monolubated, and also this one, hypolubated and abnormally hypolubated neutrophil with hyperchromatin pattern. We have one blast. This could be dysplastic left shifted, hypogranular, basophils, hypolubated, more cells, dysplastic changes. So this is a dysplastic change in the circulating neutrophils, mainly abnormality in the nuclear, few few hypogranular cells, rare blast, and this is a bizarre segmentation in the neutrophil together with monolobed neutrophils. You can tell that this is a dysplastic neutrophil comparing the cytoplasm. They have the same cytoplasm, same granularity. However, the nucleus is abnormal. So definitely all of them showing the same cytoplasmic granulation features and the nuclear chromatin pattern. So what do you think? Chronic neutrophilic leukemia, a good differential. However, in a chronic neutrophilic leukemia, you wouldn't have dysplastic features. Bilger-Howitt anomaly, usually could be, but Bilger-Howitt anomaly, they wouldn't have these abnormal leukocytosis, and the patient should be detected early in life. CMML, we don't have monocytosis, a very good differential. However, we don't have a monocytosis neither by count or by morphology. And also for CMML, you need a persistent monocytosis. So you need to go back and look for the trend of previous CBC def to confirm the persistency of monocytosis, and we don't have it in this case, but you need to make sure that your patient is not a CMML. MDS, a nice also differential. However, in MDS, you need your cytopenia, and we don't have cytopenia in this case. We have a leukocytosis. I think we have let me check. Yeah, we have anemia. We have anemia, platelet mildly low, and we have the leukocytosis. So MDS could be, yeah, you need your bone marrow to confirm this also. So clonal cytogenetic abnormality also presence. MDS, MBN, yes. So this patient found to have abnormal FISH and karyotype with deletion B53. He was negative for BCR APL1, molecular study for JAK, also on BCR APL was negative. The bone marrow done for him and found to be hypercellular, 100% cellularity with granulocytic hyperplasia, multilinear dysplasia, and less than 20% blast. There was no myelofibrosis, and the final conclusion is that the patient diagnosed as MBN MDS atypical chronic myeloid leukemia BCR LPL negative. It's under the MDS MPN, and we found that the patient is best to fit the atypical chronic myeloid leukemia. Yes, you need to rule out that the patient, the other causes for dysplastic change like folate, B12 need to be ruled out. I agree. Medication, other drugs that may lead, yes, need to be ruled out. But since that we have a clonality by fish and karyotype, this is a clonal evolution. Case 12. 67 years old female presented with persistent pancytopenia. So in this case, we have leukopenia, anemia, and thrombocytopenia. We have nucleated RBCs. You have a neutropenia. Absolute count is 0.98. So adult, 67, persistent pancytopenia. And this is your finding. So in the previous case, we have a leukocytosis, which may disrupt your finding. But in this case, I think it will gonna be very clear for you. So we have neutrophils bi-looped, and we have separated loop in the neutrophil. You have a band, and you can see that we have a thrombocytopenia. This is also a bi-looped, although we don't see the thread connection, but mostly a bilobed or abnormally lobulated neutrophil. Hypogranular also. Hypolobated, hypogranular, and this one abnormal granulocytes. More hypogranular bands. And a rare nucleated RBCs was found, and it looks also dysplastic with basophilic stippling and karyorrhexis. So what do you think in this case? Yes. Yes. MDS. Most of you get it. So an adult patient of 60 and more age, persistent pancytopenia, dysplastic change in the granulocytic cells, the neutrophils, and the available nucleated RBCs. So you need to make sure that these dysplastic change of more than 10% of the available lineage, and definitely in this case, it's more than 10% in the peripheral blood. However, you need to do your bone marrow. In this case, the flow cytometry will add nothing, since that you don't have circulating immature cells or blasts. So you need to go and do your bone marrow to check for other cell lineages, the dysplasia in the erythropoiesis, the dysplasia in the megakaryopoiesis, and also the cellularity, presence of other abnormality like fibrosis or something. And you need to do your FISH and cytogenetic to confirm or rule out presence of other of the recurrent, rule out recurrent cytogenetic abnormality and confirm that there is some marker related to myelodysplastic syndrome. Just to remind you about the morphological manifestation of dysplasia. So this is from the WHO, and most of the things should be checked up in the bone marrow. However, for peripheral blood, you may get used of the dysgranulopiesis features, presence of small to unusually large size, nuclear hyposegmentation, pseudobilgarhoate, nuclear hypersegmentation, decreased granularity or agranularity, pseudochidic higashi granule, presence of Dolly bodies or our roads. And if you been lucky to have some nucleated RBCs, as I show you in the rare nucleated RBCs. In this case, you may have the karyorrhexis, and of course you need the bone marrow definitely in the cases of the MDS. This patient bone marrow was hypercellular with tri-lineage dysplasia and excess blast of 9%. The karyotype is positive for monosomy 7, deletion 7p, and extra 2 to 4 copies of chromosomes of unknown origin. So the patient diagnosed as myelodysplastic syndrome with excess blast. So, as I told you, in the cases of MDS, peripheral blood morphology is helpful, yes, as a baseline. You need to rule out that this is not, before you do the bone marrow, this is not due to nutritional deficiencies or drug induced or presence of infection or something like this, related immunological diseases that causes the pancytopenia or the cytopenia. So peripheral blood is so helpful, but not always, and the bone marrow is the final. The decision will be kept for the bone marrow. Case 13. Okay, this is a 58 years old female with lymphadenopathy above and below diaphragm. So we have a mild leukocytosis, anemia, normocytic, normochromic, platelet is within normal, and we have lymphocytosis. So it seems that the lymphocytosis with the lymphadenopathy is alarming. So you don't know if the peripheral blood is helpful or not. So we have these cells, small lymphocytes, mature looking. These may have notching here, clumped chromatin. This is a normal neutrophils, and we have here also another small lymphocytes with notching to clifting. Very small lymphocytes, almost to the size of the red blood cells, these two. More small lymphocytes, mature looking, with clifting and notching, scant cytoplasm, clumped chromatin. Patient is an adult with lymphadenopathy. Any clue from the morphology? What do you think? Yes. Yes. At least 3 of you got it. Suggestive for follicular lymphoma. Flow on peripheral blood shows approximately 40% clonal B cells in the lymphocyte gate. It's positive. It's a clonal with Kappa light chain restriction, and positive for 19, 20, 10, and negative for 5, 38, 23. The fish is positive for the translocation 14, 18. And the patient diagnosed as follicular lymphoma, not from just the peripheral blood and fish, but also by lymph node biopsy. So this is a very nice case of follicular lymphoma with peripheral blood involvement. Next case. A 74 years old male with benign prostatic hyperplasia referred from private hospital with preliminary diagnosis of non-Hodgkin lymphoma. So you have leukocytosis, anemia, and thrombocytopenia. The differential, they counted about 60% atypical lymphocytes with lymphocytosis. So you have lymphocytosis, atypical lymphocytes, thrombocytopenia, anemia, leukocytosis, adult patient. This is the low power. So we have variability in size, some large cells, Others are smaller, the other even smaller. We have multiple basket cells, smudge cells, and we have some band here and there. Again, variable in size. Some of them looks a nicely mature small lymphocytes. Others are larger with irregularity in the nuclear contour. Chromatin is, yeah, slightly clumped. More cells. We have like indentation to grooving, irregularity in the nucleus in the large cells. Some of them looks more blastoid. Others are small with the clefting. Very nice cleft in this one and this one. Notching in the others. Very nice small lymphocytes, mature lookings. And also we have these degenerated cells, some granulocytes and monocytes. So what do you think? Lymphoma? Yes, of course, lymphoma, but what type? Any clue from the morphology? Yes. Yes, 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 yes. This is suggestive of mantle cell lymphoma, the morphology. In the mantle cell, we have different type. We have the blastoid, the small cell variant, and we have the pleomorphic mantle cell morphology. And here we have these different ranges of cells, large, small, mature lymphocytes. Some looks more blastoid. So regardless of the classification, but this is very suggestive of mantle cells. And of course, you need to go and run your immunophenotyping to confirm these assumptions and send for a FISH for the 1114 translocation. The thing is that some cases will look like a CLL by morphology, that you will have only the small mature looking lymphocytes and the flow cytometry is the diagnostic. But in this case, you shouldn't think that this is a case of CLL unless it's, for example, transforming or something else. Like in this case, it's not a classic CLL to start with. So mantle is a good differential. And this is confirmed by flow cytometry. So a 62% event in the lymphocyte gate, positive for 19.5, and 79B, FMC7, 20, 38 with lambda light chain restriction. It's negative for CD 200, 10, 23, and 138. So it's confirmed that it's mantled by translocation 1114 FISH, and the patient diagnosed as mantle cell lymphoma. Next case. A 52 years old male patient known to have diabetes mellitus, presented with 1 month history of generalized fatigability, dizziness. He's appeared pale with petechiae all over the body. So we have a leukocytosis, marked anemia, and thrombocytopenia, and 80% reported circulating blasts. Adult patients, thrombocytopenia, anemia, and circulating blast. So we have a variable size blast, a small with high INSI ratio, prominent nuclei, open chromatin. Others are larger with more cytoplasm. This one with granulations, prominent nuclei. This one is larger but without granulation. We have dysplastic chains also. So we have here pseudobilgar neutrophils with different range of blasts as we mentioned before. And also we have some dysplastic left shifted granulocyte, mostly hypogranular, and small blasts with irregular nuclear contour. So what do you think after looking to this cells? Acute leukemia? Is it lymphoid, myeloid? Okay, someone here saying a biphenotypic acute leukemia for flow. Definitely we need a flow. Most of the maturing cell here is of granulocytes. MDS AML, good differential. If the patient is documented to have an MDS before, yes. So acute myeloid leukemia with MDS related changes could be. So it looks like a myeloid leukemia. However, you need your immunophenotyping by flow cytometry. So let's have a look to the flow result. طبعا having these cells within our rods, this is myeloblast. Very nice myeloblast. But these small lymphocytes could be a lymphoblast, yes, but يعني with the maturation toward mainly granulocytes, you would think that this is more into a myeloid leukemia. So the flow cytometry detect a 61% in the events in the blast gate, positive for 34, 117, DR, MBO 13, 33, 11C, and apparent expression of CD19. So any specific cytogenetic abnormality in this case? I'm looking into the Q&A. After looking to this immunophenotyping and the morphology with dysplasia in the peripheral blood, yes, 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 most of you get it. Naif, Ashsana, Bushra, all of you are correct. Translocation 821 is expected. And the fish came positive, and the karyotype also, and the patient diagnosed as a case of acute myeloid leukemia with translocation 821. It's well known that this type of leukemia will have a co-expression of CD19 and also have the dysplastic and abnormal maturations in the bone marrow and peripheral blood. Next case, an 85 years old male presented with 3-week history of erythematous facial rash, have a leukocytosis and anemia. The white blood cells, marked leukocytosis, anemia, normocytic, normochromic, and platelet within normal. The patient have predominance of lymphocytosis in the diff. So adult patients, leukocytosis, anemia, lymphocytosis. We don't have reported circulating blast, erythematous facial rash. So we have small lymphocytes, mature looking, clumped chromatin, prominent nucleoli, cytoplasmic blips or projections. Very characteristic. What do you think? It is very diagnostic from the morphology. Adult T-cell leukemia, no. No. CLL, no. Hairy, no. Sezary, no. M6, no. So yes, this patient have the morphology of T prolymphocytic leukemia. This is a very characteristic morphology for the T prolymphocytic leukemia, and thank you for my colleague, Dr. Lubna, for this case. It's belonged to her. She was lucky enough to get 2 cases last year with T prolymphoblastic leukemia during her service. The flow cytometry analysis is crucial. In this case, we found a 90% in the lymphocyte gate with strong 45 CD45 and low site scattered. They are positive for 2357 TCR beta and co-expressing 4 and 8 together. And this is almost exclusive for the T prolymphocytic leukemia. The patient found to have TCR gene rearrangement by FISH, and he was diagnosed as T-cell prolymphocytic leukemia. This is a very characteristic morphology for the T prolymphocytic leukemia. Always remember it. Small cells, cytoplasmic bleb, prominent nucleoli, clumped chromatin, very small cells. This is my last case. A 58 years old male presented with 4 years history of generalized pruritus with poor response to antihistamine and topical treatment. He found to have a mild leukocytosis. He's not anemic. He's not thrombocytopenic. And he was found to have absolute lymphocytosis. So leukocytosis, absolute lymphocytosis. What do you think? I'm not gonna explain these cells. Yes. Yes, Noura, she got it. We have here a medium-sized cells with atypical morphology. We have the cerebriform convolution of the nucleus. It looks condensed in the some cells. The other have this convolution, deep convolution within the nucleus. So this is a very characteristic for Sezary cells. We found multiple cells with a very typical morphology for Sezary cells, showing this cerebriform presentation. The patients confirmed to have a clonal T cells by flow. It was showing a DIM7 negative 26 CD2 and reversed CD4-8 ratio. The patient diagnosed as a Sezary syndrome by tissue biopsy. However, in the blood here, we confirmed that there is involvement by cutaneous T-cell lymphoma confirmed by abnormal morphology and immunophenotyping. So this is going with the patient's condition of having Sezary syndrome. This is my last case. So I always adopt a Shafi'i saying that I believe my opinion is right with the possibility that it is wrong, and I believe the opinion of those who disagree with me is wrong with the possibility that it is right. So diagnostic hematopathology, cells differentiations, diff counting, yes, sometimes you may agree or disagree with me on the morphology, but at least we should agree on the final diagnosis, always. So I would like to open the floor for the questions. I think we have a few minutes. If you have any question, please put it in the In the diagnosis of MDS, here our colleague is asking about diagnosis of MDS. For diagnosis of MDS, you need to get a bone marrow examinations. You should never diagnose MDS by peripheral blood smear. And we are always following the WHO classification for that. How to differentiate multiple myeloma and plasma cell leukemia. In the plasma cell leukemia, you will gonna have circulating plasma cells in the peripheral blood. So diagnosis of plasma cell leukemia is having more than 20% or more than absolute count of 2 for plasma cells in the peripheral blood, okay? However, you need to confirm the clonality of these plasma cells. So if you can be able to confirm the clonality by peripheral blood flow cytometry, this is excellent. However, you need to confirm the clonality getting a bone marrow examination and getting better sample for flow and immunohistochemistry. So plasma cell leukemia could be primary or secondary. Primary as the patient will present since the beginning with many circulating plasma cells, more than 20% in the peripheral blood. Secondary, that the patient will have already a multiple myeloma or plasma cell myeloma disease in the bone marrow, and after a time, you will find the plasma cells in the circulation in the peripheral blood. In myelofibrosis, teardrop finding are a must, not always, but you may have some. If you have it, this is a clue, a very nice clue, but if you don't have it, definitely myelofibrosis is a bone marrow diagnosis. You need to have increased myelofibrosis with other, of course, criteria. Someone is asking, when we want to report initial report for peripheral blood smear, especially the mantle cell or T-lymphoblastic lymphoma leukemia, we write the percentage of the cells, or we said atypical lymphocyte in the peripheral blood smear before getting the result of bone marrow. Depend on the institute that you are working in. I recommend that you are always should follow the protocol, the guidelines, the SOPs in your hospital. However, in my hospital, yes, we document the percentage of the abnormal cells, the percentage of the immature cells or blasts or whatever circulating cells in the peripheral blood. We document this. We put a full report for the peripheral blood smear even before the result of the bone marrow. And in the bone marrow, we include the peripheral blood smear as a part of the bone marrow examination. I think this is the end of my talk. It's 9:30 now. Thank you very much for your attendance and showing an interest on this topic. Hopefully we will have more webinar about diagnostic hematology. I would like to thank the association for this chance. I would like to thank all my colleagues and all the scientists working with us in King Abdulaziz Medical City. They are doing a marvelous work and support for our diagnosis. Thank you very much. Thank you for all our resident or my consultant colleagues of hematopathologists and adult and pediatric clinical hematologists. Thank you very much, and I wish you a good night and enjoy your vacation. Thank you.